Welcome to Psychopharm Archive. I am a consultation liaison psychiatrist and academic physician. This is Catatonia. Consider a clinical presentation frequently encountered on medical wards. A patient is admitted and rapidly develops profound immobility. They lie in bed entirely mute, refusing all oral intake and actively resisting attempts at physical examination, a phenomenon known as negativism. When a clinician elevates the patient's arm, they may feel a plastic resistance, or like bending a wax candle, a classic sign known as waxy flexibility. Once released, if the limb remains suspended in midair against gravity, the clinician has demonstrated inducible catalepsy. This stands in contrast to the spontaneous catalepsy, or posturing, that the patient may exhibit for hours without external prompting. To an external observer, this severe psychomotor shutdown appears to be a complete deterioration of consciousness, a descent into an irreversible cognitive void. For decades, standard psychiatric taxonomy reinforced this assumption, swiftly classifying such presentations as an end-stage manifestation of the schizophrenia spectrum. In this analysis, we will deconstruct the profound diagnostic error that directed the trajectory of 20th century psychological medicine. By synthesizing historical and contemporary neurobiological data, integrating Edward Shorter and Max Fink's 2018 clinical history, The Madness of Fear, alongside modern systematic reviews and standard inpatient guidelines from the Academy of Psychosomatic Medicine, we will establish a precise clinical picture of catatonia. This review functions as an academic evaluation of diagnostic evolution, receptor-level pathophysiology, and standardized somatic protocols. While the patient appears checked out or unconscious, the medical reality is often the opposite. They are fully awake and experiencing extreme internal alarm. Evaluating the clinical record reveals a starkly different physiological reality for the rigid mute patient. The catatonic stupor does not represent a deficit in sensorium. Retrospective patient data demonstrates that these individuals maintain full alertness and hypervigilance, yet are paralyzed by acute, systematized anxiety. The physical rigidity is not a primary psychotic symptom, but an evolutionary analog to tonic immobility, a conserved autonomic defense mechanism initiated during periods of intense perceived threat, mediated by distinct dysfunctions in GABAergic signaling and frontoparietal motor networks. This review will systematically trace the evolution of this syndrome. We will outline Kahlbaum's 1874 systematization of the disease, analyze the subsequent taxonomic divergence formalized by Kraepelin and Bleuler, and detail the modern psychopharmacological developments that validate the condition's distinct pathology. Establishing this precise nosological boundary remains a clinical prerequisite for identifying the syndrome and executing rapid, targeted somatic interventions. Before we had a single name for it, doctors used many different confusing terms for these symptoms, which made it impossible to study the underlying brain science. To understand the current clinical utility of catatonia, we must first examine the fragmented landscape of the early 19th century. Prior to a unified systematization, the European medical literature contained only disjointed descriptions of what we now recognize as a singular syndrome. Clinicians utilized disparate labels such as catalepsy, lethargy, or stupidity to describe patients who presented with profound motoric arrest. These anomalies were largely viewed as secondary, non-specific complications of various underlying conditions rather than manifestations of a unified physiological state. The lack of a cohesive framework meant that the underlying neurobiology remained obscured by the variety of symptomatic expressions. This era of diagnostic confusion finally came to an end when one physician began to see a consistent pattern hidden within these diverse symptoms. The nosological paradigm shifted fundamentally in 1874 with the publication of Die Catatonie oder das Spannungserscheinen by German psychiatrist Karl Ludwig Kahlbaum. Utilizing a rigorous observational method, Kahlbaum was the first clinician to systematically aggregate a specific constellation of motoric and behavioral signs, including mutism, negativism, waxy flexibility, stereotypy, and verbigeration, into a singular independent disease entity which he termed Viscenia catatonica. Crucially, Kahlbaum did not view these signs as mere additions to a psychotic illness. Instead, His data supported a conceptualization of catatonia as a systemic, cyclical disorder of motor function and mood. He documented its episodic nature and, most importantly, observed that these patients frequently achieved complete recovery, establishing catatonia as a discrete illness with a frequently favorable prognosis, entirely distinct from progressive cognitive decline. While Kahlbaum's work provided a clear and hopeful definition of the disorder, it was soon overshadowed by a new medical movement that prioritized broad classification over specific recovery patterns. However, this precise clinical boundary was systematically dismantled at the turn of the 20th century, an era dominated by the push for broad psychiatric categories. In the 1899 sixth edition of his highly influential textbook, Emil Kraepelin fundamentally reorganized psychiatric taxonomy by introducing the concept of dementia praecox. This diagnostic category was predicated on the assumption of an irreversible progressive deterioration toward a terminal state, relying primarily on cross-sectional institutional observations rather than longitudinal outcomes. Kraepelin subsumed Kahlbaum's catatonia into this framework, reclassifying it as a primary subtype of dementia praecox. By doing so, he inextricably linked a rapidly reversible psychomotor syndrome to a diagnosis defined by chronic decline. This link became even more permanent when the focus of psychiatry shifted from physical symptoms to the inner workings of the mind. This taxonomic error was further entrenched by Eugen Bleuler in 1911 with the publication of Dementia Praecox, or the group of schizophrenias. While Bleuler expanded the psychological criteria of the disorder, he maintained Kraepelin's structural subsumption. In the Bleulerian framework, motor signs were relegated to the status of accessory symptoms, while the fundamental features of the illness were defined by intrapsychic splitting and the 4 A's: affect, associations, ambivalence, and autism. Bleuler's interpretation moved further away from Kahlbaum's physiological observations, attributing profound motoric deficits to hypothesized psychoanalytic mechanisms and symbolic internal conflicts. This conceptual shift effectively buried the motoric reality of the syndrome beneath layers of psychological speculation. Because the medical world began to see catatonia only as a symptom of schizophrenia, they missed its presence in many other types of patients. The consequence of this integration into the schizophrenia spectrum was a profound narrowing of clinical perception. For most of the 20th century, catatonia was increasingly conceptualized as a late-stage secondary manifestation of severe psychosis. This restriction significantly delayed the recognition of the syndrome in other clinical contexts. The original data from the Kahlbaum era, demonstrating that catatonia functioned independently and was more frequently associated with underlying medical and mood disorders, was largely marginalized. As a result, patients presenting with acute catatonic stupor in the context of a primary affective disorder or a systemic medical illness were often misdiagnosed and subjected to inappropriate or delayed treatment protocols. The modern restoration catatonia as a discrete clinical entity. Modern systematic reviews, including the work of Dusan Herjak and colleagues in 2022, have utilized these historical data to validate that the original Kraepelinian subtype model was fundamentally flawed. Large-scale epidemiological studies now confirm that catatonia is more prevalent in the context of bipolar disorder and major depressive disorder than in primary psychotic illnesses. Furthermore, the rapid and complete reversal of symptoms following targeted somatic intervention, such as the Lorazepam challenge, provides a level of diagnostic validation that is absent in chronic schizophrenia. This physiological reactivity serves as a powerful indicator that catatonia operates via distinct neural pathways, independent of the cognitive parameters of dementia praecox. Today's data proves that catatonia is not a permanent state of decline, but a specific physical reaction that can often be reversed quickly with the right medication. The formal correction of this century-long error only began in earnest with the release of the DSM-5 and subsequently the ICD-11. These modern frameworks have finally decoupled catatonia from schizophrenia, establishing it as a standalone clinical specifier that can be applied across a broad range of psychiatric and general medical conditions. This shift represents a return to Kahlbaum's original 1874 vision, a recognition of catatonia as a discrete, observable psychomotor syndrome. Reclaiming this nosological independence is not merely a matter of academic taxonomy, it is a clinical prerequisite. By identifying the syndrome as a unique physiological state, we move away from the assumption of chronicity and toward a model of acute rescue and recovery. By separating catatonia from schizophrenia in our official medical manuals, we can finally study exactly what is happening in the brain during these episodes. beyond the surface, mapping the circuitry of the frozen brain. Establishing this precise boundary allows us to investigate the underlying biology without the confounding variables of primary psychosis. As we move from history to neurobiology, we must ask, what is occurring in the brain of the frozen patient? The answer lies not in intrapsychic splitting, but in precise dysfunctions within the frontoparietal motor networks and the evolutionary mechanisms of survival. This transition from taxonomic observation to molecular and functional analysis forms the basis of our next inquiry into the frozen brain. While we are beginning to map these brain changes, it is important to remember that every patient is different and our scientific understanding is still evolving. To investigate the neurobiology of catatonia is to examine a profound failure of the neural architecture responsible for the initiation and modulation of movement. However, it is a clinical and scientific necessity to acknowledge that our current models remain provisional and that none of these findings are absolute. The neurobiological landscape of catatonia is characterized by significant heterogeneity, and establishing definitive causal mechanisms in human subjects remains exceptionally difficult due to the acute nature of the syndrome and the logistical challenges of studying patients in the midst of a behavioral crisis. Transitioning from taxonomic history into functional anatomy, we move beyond the clinical observation of stupor into the quantitative, though often preliminary data provided by modern neuroimaging. Modern brain scans show us that the frozen state isn't caused by a brain that is shut down, but rather by specific areas that aren't communicating correctly. The frozen appearance of the catatonic patient is not a state of neural inactivity, but the result of localized circuit dysfunctions. Systematic reviews of functional magnetic resonance imaging, fMRI, and single photon emission computed tomography, SPECT data, most notably the 2024 analysis by Duke and colleagues published in the Journal of Psychosomatic Research, reveal a consistent pattern of reduced regional cerebral blood flow and diminished metabolic activity in the right-sided prefrontal and parietal cortices. This right lateralized deficit suggests that catatonia is a disorder of the higher-order executive networks that govern motoric intent and behavioral inhibition. Yet, as Duke and colleagues note, these neuroimaging findings are difficult to generalize across the entire population of affected individuals given the small sample sizes and the inherent variability in underlying etiology. The molecular gridlock, GABA, glutamate, and the frozen brain. A central component of this hypothesized top-down dysfunction is located within the orbitofrontal cortex and the medial prefrontal cortex. These regions are critical for the integration of emotional state with motoric output. In the catatonic state, the medial prefrontal cortex demonstrates significant hypoactivity, which correlates directly with the clinical sign of negativism. When the orbitofrontal cortex is functionally compromised, the brain may lose its ability to appropriately modulate behavioral responses to perceived environmental threats. This localized cortical shutdown creates a vacuum in motoric initiation, where the patient remains physically capable of movement but is neurologically unable to generate the signal required to bridge the gap between intent and action. It must be stated, however, that these specific circuit dysfunctions are difficult to demonstrate in real time in humans, and much of our understanding is derived from indirect clinical observations. While these brain regions provide the map of the problem, the actual fuel causing the engine to stall is a precise imbalance of brain chemicals. The cortical deficits observed in neuroimaging are likely driven by a precise molecular imbalance, specifically the hypothesis of gamma-aminobutyric acid or GABAergic hypofunction. The GABA-A receptor is the primary mediator of inhibitory signaling within the human central nervous system. Technical data from the 2022 review by Ariza Salamanca and colleagues in Frontiers in Molecular Neuroscience, alongside the 2024 Nature Review's Disease Primer by Herjak and colleagues, suggest a significant downregulation or functional blockade of GABA-A receptors within the prefrontal and parietal networks. This loss of inhibitory tone is concentrated in the circuits that typically suppress maladaptive motoric responses. This GABA hypofunction model provides the pharmacological rationale for the Lorazepam challenge, but researchers continue to emphasize that direct molecular evidence in living human patients is notoriously hard to obtain, making this a working hypothesis rather than an absolute fact. As the brain loses its ability to inhibit certain signals, other parts of the brain become overloaded with excitatory signals, creating a state of internal interference. Complementing this top-down cortical failure is a bottom-up dysfunction involving glutamatergic overactivity and basal ganglia interference. While the cortex suffers from a lack of inhibition, the subcortical structures, specifically the striatum and the thalamus, appear to be in a state of excitatory overload. The NMDA receptor, the primary mediator of excitatory glutamatergic signaling, plays a pivotal role here. Excessive NMDA receptor activity within the basal ganglia circuits can lead to a physiological blockade of the thalamocortical pathways. This creates a state of functional interference where the motor signals from the basal ganglia are disorganized or entirely suppressed before they can reach the primary motor cortex. This interaction between GABA-A hypofunction and NMDA overactivity forms the dual-hit neurobiological framework, though the intricate details of this crosstalk remain challenging to map definitively in human neurobiology. This biological gridlock may actually be a primitive survival mechanism that has been switched on by mistake, leaving the patient stuck in an ancient defense mode. This neurobiological gridlock takes on a deeper significance when viewed through an evolutionary lens. As established by Edward Shorter and Max Fink in the 2018 text The Madness of Fear, the physiological state of catatonia is conceptualized as a conserved autonomic defense mechanism. In the animal kingdom, this is recognized as tonic immobility, the survival response triggered by inescapable predatory threat. When a human experiences a state of extreme systematized anxiety, the brain may default to this primitive survival program. The regional cerebral blood flow deficits and the subsequent GABA-A downregulation represent the biological signature of this evolutionary override. While this evolutionary analog provides a compelling theoretical framework, it remains difficult to prove in a clinical setting and does not account for all presentations. The patient is not refusing to move in a psychological sense. They are experiencing a subcortical survival reflex that has effectively hijacked the higher-order motor systems. From primitive reflex to precision measurement, the clinical landscape. In a catatonic stupor, the patient's internal state is often one of hypervigilance and intense autonomic arousal, despite their outward appearance of total immobility. The tachycardia and diaphoresis often seen in these patients are objective markers of this internal fear circuit activation. This perspective shifts the clinician's role toward acute physiological stabilization. We are treating a brain that has locked itself into a terminal survival mode, and our interventions must be calibrated to unlock these specific GABAergic and glutamatergic checkpoints. This granular neurobiology illustrates why broad-spectrum treatments like traditional antipsychotics are often insufficient, but none of these models should be viewed as absolute. By grounding the clinical approach in this functional architecture while remaining cognizant of the difficulty in demonstrating these mechanisms in humans, we move away from trial-and-error prescribing and toward a model of targeted somatic rescue. Because the frozen patient is actually in a state of high internal alarm, doctors need a consistent way to measure these subtle physical signs that aren't always obvious at first glance. The transition from theoretical neurobiology to clinical practice is defined by the necessity of objective standardized measurement. Despite the granular understanding of the circuit dysfunctions previously discussed, catatonia remains one of the most under-recognized syndromes in modern medicine, with detection rates often failing to capture its heterogeneous presentations. This diagnostic deficit served as the primary catalyst for the development of the Bush-Francis Catatonia Rating Scale, BFCRS, as documented in the foundational 1996 validation study by Gabor Bush and Andrew Francis, conducted under the clinical mentorship of Max Fink. The scale was designed to operationalize catatonia as a discrete, observable syndrome, moving the field beyond the restrictive Kraepelinian focus on end-stage stupor and toward a semi-structured neurological examination. This medical checklist is divided into two parts, one for a quick check in emergencies and another for a more detailed look at how the patient is responding to treatment over time. In the 2024 Nature Reviews Disease Primer, Herjak and colleagues delineate why the BFCRS remains the global gold standard for identifying the full spectrum of psychomotor phenomena. The technical architecture of the instrument is divided into two distinct components, a 14-item screening tool and a 23-item severity scale. This structural division, as refined in the original Francis papers, allows for rapid, high-sensitivity screening in acute environments, such as the emergency department or intensive care unit, while providing the longitudinal granularity required to track treatment response. The diagnostic threshold is intentionally low to ensure clinical vigilance, as established in the 2014 clinical review by Sienna Ert and colleagues in Frontiers in Psychiatry. The presence of just 2 items on the screening tool necessitates a comprehensive diagnostic evaluation. The scale works by helping doctors spot very specific, unusual body movements that act as clues to which parts of the brain's wiring are experiencing interference. The clinical utility of the scale lies in its surgical precision of definition. It requires the clinician to differentiate between nuanced motoric signs that serve as proxies for specific neural circuit disruptions. For example, the scale distinguishes Mitgehen, the doing along phenomenon where a patient moves in response to light pressure despite instructions to resist, from Gegenhalten, which is the active proportional resistance to passive movement. These signs, along with phenomena such as ambitendency and verbigeration, provide the clinician with a real-time assessment of the interference within the frontoparietal and basal ganglia networks described in the functional neuroimaging data. The strategy of somatic rescue, unlocking the brain. Beyond initial detection, the BFCRS functions as the primary metric for the Lorazepam challenge and subsequent somatic interventions. By quantifying the psychomotor state before and after the administration of a GABA-A agonist, clinicians can objectively verify the 50% reduction in symptom severity that validates the diagnosis. Furthermore, as highlighted in the monographs from the Academy of Psychosomatic Medicine, the systematic use of the scale allows for the early detection of the malignant shift. By monitoring the autonomic items on the severity scale, the clinical team can identify the onset of autonomic instability before the development of life-threatening hyperthermia, allowing for the immediate escalation to specialized protocols. This move from subjective observation to standardized measurement is what allows for the rapid, targeted rescue of the catatonic patient. Once the condition is measured and confirmed, the focus shifts to a rescue mission using specific medications to jumpstart the brain's stalled circuitry. The identification of catatonia through standardized instruments like the Bush-Francis scale is the essential prelude to executing the somatic rescue. The clinical objective is the rapid restoration of homeostatic equilibrium within the dysregulated motor circuits. As detailed in the 2014 clinical review by Sienna Ert and colleagues in Frontiers in Psychiatry, the first-line intervention remains the aggressive administration of high-potency benzodiazepines, specifically Lorazepam. This pharmacological strategy is predicated on the GABA-A hypofunction hypothesis. By providing an exogenous GABA-A agonist, we are attempting to rectify the inhibitory deficit in the orbitofrontal and parietal cortices. Successful treatment often requires much higher doses than usual, because the goal isn't to make the patient sleepy, but to physically unlock their ability to move. The Sienna protocol emphasizes that treatment failure is often an artifact of subtherapeutic dosing. The Lorazepam challenge begins with a 1 to 2 milligram dose, typically administered intravenously for rapid bioavailability, but the titration must be decisive. In inpatient settings, daily requirements frequently escalate to 8 to 16 milligrams. This high-dose requirement reflects the severity of the receptor level downregulation. The objective is not sedation, but the functional unlocking of the motoric blockade. As the GABA-A receptors are re-engaged, we often observe a dramatic and near-instantaneous reversal of mutism and stupor, providing a powerful validation of the underlying pathophysiology. While some medications act as a key to unlock the brain, others can act like a second deadbolt, potentially turning a treatable condition into a life-threatening emergency. However, the clinical landscape becomes significantly more precarious when traditional psychiatric interventions are misapplied. Utilizing the molecular framework provided by Ariza Salamanca and colleagues in 2022, we must recognize the grave danger posed by D2 receptor antagonists or traditional neuroleptics. In a catatonic state, the basal ganglia are already compromised by a hypodopaminergic environment. Introducing agents like haloperidol further depletes dopamine signaling, which can catalyze the transition from simple catatonia into the life-threatening autonomic collapse of malignant catatonia, or neuroleptic malignant syndrome. This pharmacological sensitivity is a hallmark of the syndrome. Thus, the premature use of antipsychotics before the motoric syndrome is stabilized represents a critical deviation from established safety protocols. Beyond benzodiazepines, advanced stabilization, and the definitive rescue, For the approximately 20 to 30% of patients who do not achieve full remission with benzodiazepines alone, the clinical algorithm moves toward bottom-up circuit stabilization via glutamatergic modulation. Siena-Ert's 2014 review and the 2022 technical data from Ariza Salamanca support the use of NMDA receptor antagonists, such as amantadine or memantine. The rationale is to suppress the glutamate storm occurring in the subcortical structures. By reducing excitatory signaling at the NMDA receptors, these agents mitigate the functional interference within the basal ganglia thalamocortical loops, providing a necessary counterbalance to the top-down GABAergic failure. If medications cannot calm the brain's signaling storm, doctors use a highly effective treatment that resets the brain's electrical and chemical balance all at once. When pharmacological rescue is insufficient, or when the patient exhibits signs of autonomic instability such as hyperthermia, tachycardia, and labile blood pressure, the gold standard intervention is electroconvulsive therapy, ECT. The evidence-based monographs from the Academy of Psychosomatic Medicine position ECT as a highly effective, life-saving treatment with response rates often exceeding 80%. The neurobiological mechanism of ECT in catatonia is thought to involve a massive synchronous release of GABA and a subsequent upregulation of GABA-A receptors, effectively resetting the cortical inhibitory tone more profoundly than pharmacological agonists. Crucially, the Academy of Psychosomatic Medicine guidelines suggest that for malignant presentations, ECT should not be viewed as a last resort, but as a primary intervention to be initiated within 48 to 72 hours of failed pharmacological challenge. Because other serious conditions can look exactly like catatonia, doctors must use brainwave tests to ensure they are treating the right underlying problem. The clinical management of catatonia also requires a high degree of diagnostic vigilance regarding medical mimics. In cases where the psychomotor presentation is atypical or entirely resistant to standard rescue protocols, the clinician must utilize electroencephalography, EEG, to differentiate catatonia from non-convulsive status epilepticus. As highlighted in the 2024 Nature Reviews Disease Primer by Herjak and colleagues, the clinical signs of non-convulsive status epilepticus can be indistinguishable from catatonic stupor, yet the treatment pathways are fundamentally different. Establishing the absence of ictal activity is an essential component of a comprehensive medical evaluation, ensuring that the somatic rescue is directed at the correct neurological pathology. The ultimate goal of this medical hierarchy is to move the patient out of an ancient survival freeze and back into a state where their brain can once again control their body. The clinical rescue of the catatonic patient is a high-stakes execution of neurobiological theory. The evidence-based hierarchy prioritizes the restoration of GABA-A inhibitory tone through aggressive Lorazepam titration as established by Siena-Ert in 2014. This must be balanced against the absolute avoidance of D2 blockade to prevent the conversion to malignant catatonia, a risk detailed in the molecular data from Ariza Salamanca in 2022. For treatment-resistant cases, the algorithm incorporates bottom-up stabilization with NMDA antagonists, or the rapid escalation to ECT, which the Academy of Psychosomatic Medicine recognizes as the definitive treatment for autonomic instability. Success in these interventions requires the constant standardized monitoring provided by the Bush-Francis scale to track the functional recovery of the frontoparietal motor networks. By adhering to this rigorous somatic hierarchy, we transition the patient from the primitive evolutionary state of tonic immobility back to a state of regulated neurochemical and motoric function. The future of recovery, from chronic decline to clinical rescue. The historical trajectory of catatonia serves as a cautionary narrative regarding the impact of taxonomic classification on clinical outcomes. For over a century, the integration of this syndrome into the schizophrenia spectrum effectively obscured its underlying physiology and condemned patients to a prognosis of terminal decline. By reclaiming catatonia as an independent entity, we align ourselves with the original clinical data of the Kahlbaum era and the objective findings of modern neuroimaging and molecular biology. We move from a model of chronic institutionalization to a model of acute medical rescue. By separating catatonia from schizophrenia, we shift our focus from managing a lifelong illness to treating an acute medical emergency. Our current understanding, grounded in the molecular dynamics of GABA-A hypofunction and the functional neuroimaging of frontoparietal motor networks, dictates a clear clinical mandate. The recognition of catatonia through standardized instruments like the Bush-Francis scale is not merely a diagnostic exercise, it is the prerequisite for initiating life-saving somatic interventions. Whether through the high-dose titration of benzodiazepines, the modulation of glutamatergic signaling, or the execution of electroconvulsive therapy, the goal remains the same: the rapid restoration of motoric and autonomic homeostasis. As doctors, our job is to stay alert for these symptoms everywhere, from the ER to the hospital ward, treating the frozen state as a physical blockage that can be cleared. As academic physicians and clinicians, our duty is to maintain diagnostic vigilance in every clinical setting, from the emergency department to the inpatient ward, by applying the rigorous data synthesized from the current literature, including the 2024 Nature Reviews Disease Primer by Herjak and colleagues, the 2018 Historical Synthesis by Shorter and Fink, and the clinical guidelines of the Academy of Psychosomatic Medicine. We ensure that the frozen patient is no longer viewed as an enigma of the sensorium, but as an individual suffering from a rapidly reversible neurological blockade. This commitment to technical precision and evidence-based practice is the foundation of modern psychological medicine. This modern approach allows us to help patients who were once considered hopeless by using precise science to restart the brain's natural ability to function. The transition from the Kraepelinian view of terminal chronicity to the modern model of acute recovery represents one of the most significant corrections in the history of the field. By treating catatonia as a discrete, observable syndrome regardless of the primary diagnosis, we unlock the potential for complete remission in cases previously thought to be irreversible. This synthesis of historical nosology and modern neuroscience serves as the definitive framework for the contemporary management of the catatonic state. Success in this domain requires the rejection of outdated psychological interpretations in favor of the molecular and circuit-based models that define the current era of clinical medicine. By applying the rigorous data synthesized from the work of Herjak, Shorter, and Fink, and the Academy of Psychosomatic Medicine, we ensure that the frozen patient is no longer viewed as an enigma, but as an individual suffering from a rapidly reversible neurological blockade. This commitment to technical precision and evidence-based practice is the foundation of modern psychological medicine. For Psychopharm Archive, I am a consultation liaison psychiatrist and academic physician. If you value this high-level analysis of neurochemistry and clinical history, subscribe for our next deep dive into the molecules that shape the modern world.